India has one of the highest maternal and child mortality rates in the world, right? India accounts for 9% of global maternal mortality. 2 children under age 5 die every minute in the country. In the next 1 hour of this podcast, 3 women are going to die in labor somewhere in the country. Like postpartum depression, postpartum blues, that nobody cares about that. You're supposed to feel immense love for the child as soon as the baby is born and not realize that you're going through so many changes, right? Hormonal changes, physical changes. No one gives time to the mother. The health system, doctors and nurses, because it's so overcrowded, it's impossible. 2 hours, you can't be seeing so many patients. And that's the whole system, systemic issue that's happening, right? Pervasive systemic problems, right? I saw this over and over again, right? Completely preventable issues leading to mortality. Our government hospitals have so much, potential, right? I mean, the kind of patients we get, the kind of, amenities that can be made available to women, the potential is immense. And I knew that I want to build a fellowship program, but I want to do it in a government hospital.
So I've just finished recording a podcast with Dr. Aparna Hegde, and it's opened my mind, and I wanted to give you this introduction before you go watch the podcast, which is coming up next. Dr. Aparna Hegde is a Stanford and Cleveland Clinic trained world-class doctor in urogynecology. She could have stayed in the US, but she chose to come to India and make her skills available to the poorest in this country. Now, she runs a private practice, but she's also head of the Department of Urogynecology that she's building at Cama Hospital, which will offer world-class treatment for women completely free. She's also founded and running a NGO called ARMMAN for the last 7 years, where they have trained 8.5 lakh health workers across the country to help women who are pregnant, who have just had babies. And they have also communicated with and changed the lives of 70 million women across India by giving them the information they need in order to have safe pregnancies and childbirth. I've really enjoyed having this conversation, and I hope you enjoy listening as well. This is Dr. Aparna Hegde. Thank you so much for coming over to the home studio to have this conversation. I'm very excited about this conversation. I have a lot to ask you about the work that you're currently doing, but I want to start with why you decided to become a doctor or a gynecologist. What was that journey like?
Yeah, so I'm a urogynecologist now.
Yes.
And the journey started from my childhood. I was born and brought up in Mumbai, and I grew up actually in Pantnagar, a place called Pantnagar in Ghatkopar, and it was a housing board kind of society, and the typical chawl kind of environment. And luckily I was born in a family which was focused on education. You have the caste privilege, you really get pushed into education, and there was always this support of books, and the environment was full of that, despite the fact that I lived in Pantnagar. But I saw very closely my my neighbors' children, and and families suffering from the lockdowns of those days. There used to be these lockouts of in industries those days, socialist India. And I saw very closely how poverty can make that big difference between you becoming a doctor and you working as a laborer or as a vegetable seller in the local market, right? And I was always aware of my privilege, right? The privilege of birth, the fact that because I was born where I was, and because I didn't have a choice over that, right? And that was something given to me. And I went to a good school, and I'm here talking to you, and the same privilege. It was not accorded to so many other people I saw. I could have been just one girl breaking bricks by the roadside if just not, if I had not been born in the family that I was. And so I was always aware of this privilege. And also imagine Mumbai, right? We are born in Mumbai, and India has so many centuries living together.
Yes.
I was so aware as a Mumbai girl, the kind of privilege I had, right? I could go from Ghatkopar all the way to Stanford University, whereas just even though I was a girl from Mumbai. And I could have been born in Haryana, and facing all the kind of gender disparity that is still prevalent today. So all through childhood I was aware of that, and I realized that it was very important for me to ensure that the privileges I had, I could share with others, and use the opportunities I had been given to be able to kind of take that to women and children that didn't have access to it. And then I was always a science person. I just loved really science. I mean, I've always wanted to, actually initially be an engineer, but then I realized that medical profession was one field that combined the sense of service I always had with science. And also research, right? So for me, I mean, I will always imagine myself as being a researcher, contributing to the field going forward that I was a part of. And so medicine seemed like a really beautiful amalgamation between service, science and research, right? And that's why I wanted to become a doctor.
And so you made this decision, I'm assuming, at 17, 18? Or
yeah, I mean,
did you have to start studying at the 6th standard to become a doctor? How did that?
So I think all along it was engineering. I mean, I love maths, so my favorite subjects were maths and physics.
Right.
Yeah, I to date miss maths. I, in fact, even after I entered MBBS for a while, I was like, you know, studied maths.
Because you just missed it.
Yeah, I missed it. I miss it even now. And I'm so happy that right now I'm in a field that takes me back to the physical sciences. Urogynecologist, the field I'm doing, has a lot of functional disorders that deal with, you know, physical problems of the body, which like are very logical and, you know, depend on physics kind of, equations, etc. But yeah, I mean, so all along it was engineering actually, you know, and and you carried that craze of, you know, doing maths and physics, quizzes with all your colleagues, you know, who are in the same field. But then as I was, progressing through my, studies, it dawned on me that medicine is one field where I can marry that love for, logical sciences, the physical sciences, and maths with actual service.
How did you wind up in Stanford? What was that journey? Like you did your MBBS in India and you then went to Stanford?
No. So, I finished my MBBS. I also finished my MD Gynec in India, in Cama Hospital. And then, I really had an epiphany. I went through some health problems. That was a long-standing, issue. I had studied laparoscopic surgery. I did a fellowship in laparoscopic surgery after MD Gynec. And then I really had an epiphany. I was like, what was I becoming a doctor for? Like, what is the thing that I'm looking forward to? Was my goal to do 100 hysterectomies a year? And was I really achieving what I really want to do with my, future? I mean, my goals in life were science, service, and research. And I thought that I was nowhere. I was looking forward to a career of, a private practice in laparoscopic surgery, and it's all great. But was I really contributing to the science? Was I really doing any research? And was I really serving, right? Because the kind of medicine we were practicing, though, when you work in government hospitals, you think you're serving people, but you actually are not, right? It's a part of the job that you're doing. It's supposed to be done well, but not necessarily that, you're actually actualizing all the service dreams that you have. And my residency days, brought close to me, how, working in that environment, I maybe was not really, serving women to the extent that I really hoped to do as, when I entered medicine. And that epiphany led to two journeys. One was really, realizing that no, I'm not going to go and join private practice or a big corporate hospital immediately after doing laparoscopic surgery. Actually, I'm going to go ahead and study further, right? Contribute to the sciences. So I actually went and did biological sciences at Stanford because I wanted to be a researcher, right? I wanted to kind of, ensure that. And then I went on to doing a fellowship in Cleveland Clinic in Urogynaecology because, it took me to the, cutting edge of my field, right? And at the same time, I started ARMMAN because that was service, right? So all these two paths came together, and that's how I ended up in Stanford and then Cleveland Clinic. And then
no, but this is the interesting thing, right? I know a lot of my peers who studied medicine and then went overseas, and Stanford and Cleveland Clinic are the best in America. It would have been very easy for you to stay back and have a very comfortable life, great work-life balance, and make a lot of money.
Yeah.
Why didn't you?
I always knew I wanted to come back. I always knew that I wanted to use my skills and my knowledge to contribute back home. Right? There were two dreams, right? I already built ARMMAN, right? And I was running ARMMAN from the US. Like I founded ARMMAN during my first year in Stanford. For the next 6 years, I managed ARMMAN from the US. And I knew I wanted to come back to India and take it through the country, right? That was an important dream, and nothing could, make me stay back in the US, because I knew that I had to be back to be ensured that, it really achieved the goals that it was created for. Second thing was that, I had studied a field that didn't exist in the country. I was in Urogynaecology. There was no fellowship program in the country. And 1 in 4 women suffer from these conditions, and it was so important for me that I come back to India and build urogynecology in the country, help to build, I mean, and ensure that the poorest have access to my, medical skills. The thing that really bothered me was that, when you study more and more and more, you outprice yourself. The people who need it the most don't have access to you.
Yeah.
So if I'd stayed back in, US and worked as a professor, I mean, I was always an academic person, so I would have, become a professor, something like that in the United States. I mean, the people who needed me the most or needed access to my skill the most wouldn't have had that, right? And, where but in India do you see, the extreme ravages of the field that I am in, right? So it is so important to not only come back to India, but also come to government system.
So I want to ask you about various things you brought up, but first let's talk about ARMMAN. So apart from the fact that you have your private practice, you have the practice in government hospitals, you are running a not-for-profit called ARMMAN, which is, I know, you've talked about a lot, which is your dream project, with the aim to give access to healthcare information to the poorest women. Is that correct?
So ARMMAN is a maternal and child health NGO. It leverages technology to create cost-effective, scalable solutions to, on the one hand, inform women about the care to be taken during pregnancy and infancy, so they demand care, and on the other hand, train health workers at every level of the health system, so they can give care early enough before it's too late, so that you don't have overcrowding of tertiary hospitals because of delayed referrals, complicated referrals, or irrational referrals. Women and children just landing up in tertiary hospital like Cama Hospital without any care, so they're dying, or they just being sent without any care being given at the primary level, leading to overcrowding and the increased mortality and morbidity that I saw in Cama Hospital. And all of this came from my experiences during residency. When you work in a hospital like Cama Hospital, you see very closely how extremely preventable problems, right? They're systemic, they're pervasive, but they're very preventable. Leads to loss of lives of mothers and children. They're so horrific, it's just the indignity of it all, right? Like, if just they had access to right information at the right time, or if only the health worker knew how to pick up the risk factor in time, they could have been saved such horrific deaths, So, and I can tell you and there's so many stories, right, that I saw over and over again, and I'll just tell you this one story that, really encompasses all that is, so wrong with our health system, right? So if you look at why women and children die in the country, there's something called as a 3 delay model, right? So there are 3 delays that explain why women and children don't have access to health care. The first delay is lack of access to information.
Yes.
If during pregnancy and infancy, you've had a child recently and you know how pregnancy and infancy are dynamic periods, right?
Yes.
I mean, things change from week to week.
Week to week.
Yeah. Absolutely.
Yeah.
And if you're not aware, you don't know how to access care, where to go, what to do, what are the danger signs.
So what to expect when you're expecting, that information.
That information, if you don't have, there's going to be delay. That's the first delay. So you access care too late. Second delay is when you finally are aware, oh, you have a big problem and it's an emergency, you don't know where to go, right? There are no roads, there are no ambulances, right? Third delay is when you reach a hospital, nothing exists. There is no equipment, there is no staff, there is no supplies, there is no facilities. So these 3 delays have led to a situation where India has one of the highest maternal and child mortality rates in the world, right? India accounts for 9% of global maternal mortality. 2 children under age 5 die every minute in the country. In the next 1 hour of this podcast, 3 women are going to die in labor somewhere in the country. And and I give these numbers, you don't really understand those gaudy stories behind. So I'm going to tell you this one story, right? And it's a little difficult story, so really forgive me, people who are listening to this. So I'm just going to give a disclaimer here. Yeah. But this is something important, because I don't think we get exposed to this, the kind of horror that are hidden behind, even beneath our, easy lives. And this happened in Mumbai, right? I'm not even talking about a rural India story, right? So this is my first 3 months of residency. And there was this patient, I would call her Aruna. She went to Thane Civil Hospital, right? And Thane is a really great suburb, and this hospital is a really good one, right? She goes to Thane Civil Hospital in 3rd month of pregnancy. And we always tell women, go and access care, go and access care. She did.
She did.
She did, right? So she goes there, and as usual, hugely overcrowded clinic, 200 patients waiting outside, extreme apathy. You heard it like cattle here and there. It's so hot, it's humid. You're like packed like sardines in a small space. You wait for 3-4 hours, and then you get 1 minute with a nurse who doesn't even look at your face, right? And so she, obviously the nurse has told her, take some medication and come back next time. She never went back, right? Who's going to go back to that situation? So she didn't understand the reason, the need for antenatal care. 5th month, she developed gestational diabetes. That's diabetes in pregnancy. So when you develop diabetes in pregnancy, often the baby dies in the womb, but her baby survived, right? And look at what happened. Look at the sequence of events, right?
And gestational diabetes can only be found out if you're doing regular blood tests.
Absolutely. In the 5th month, you do a blood test where you pick up, because you can't even pick it up before that, right?
Yes.
The 4th, 5th month is when you do a blood test and you pick up diabetes in the mother. And if you didn't pick up, then these things, that the eventual, sequelae of, what happened to her wouldn't have happened. 9th month, she goes into labor unaware, right? Goes Friday evening. The worst time to go into labor in Mumbai city is Friday evening, right? She goes into labor, goes to Thane Civil back. A nurse there, not trained since last 30 years of nursing school, did not realize there's a problem. Now her baby was exposed to so much sugar in the body, right? Because she was diabetic. So the baby's body was huge and the head remained small. And the nurse, unaware, started delivering her, right? The head delivered and the body remained stuck inside. And the baby died immediately, right? Now it's a question of saving her life. The doctor was doing private practice somewhere else. So it took her half an hour to get the doctor down, right? And the doctor realized that we have to do a C-section immediately, cesarean section. Now there is an operation theatre, but no anesthetist after work hours. So now you have to transfer, right? And now if you transfer, you need an ambulance. And there's no driver after work hours. So now you have to get a private ambulance service provider. So it takes half an hour to call, all these private ambulance service providers before they get one. So 1.5 hours after the baby's head pops out, they transfer. And 1.5 hours more through the horrible Mumbai traffic Friday evening, they reach Cama Hospital. And I was a rookie first poster. It was my emergency duty. And I've recounted this story countless times. And it gives me goosebumps every time I remember the sight, right? I can see it in my mind's eye. I opened a petticoat. There was this black pawny baby head sticking out of the vulva. And her lower part was getting gangrenous. She was sinking. Yeah. So I immediately called all my seniors down. They came running down. We tried to take the baby out from below. It was not possible. It was all jammed, right? Because all congealed, congested, edematous, stuck.
3.5 hours.
Yeah, absolutely. So we had to take her for C-section, cesarean section, right? So all my seniors scrubbed up and they started operating on her and they cut her abdomen from above. And unfortunately, they couldn't take the baby out from above also. It was all jammed. And so the deed fell on me. I was the only unscrubbed junior. I had to make things ready, so I was not scrubbed in. I had to take a knife and behead the baby on table. And because you cannot give a beheaded baby to the parents, I had to take a needle and twine and stitch the baby's head on the body. And then she died 3 days later. Look at these sequelae, right? Look at what happened, right? Look at horrific things that can happen to a woman and child if only, if that blood test is not done, right? It is so preventable, right? She come in the 5th month of pregnancy, they've done a blood test and she had come, right? And you can't even blame the nurse. I have been a part of clinics, right? And I remember my time in Cama Hospital as a resident. I can tell you there have been times where, overcrowded clinics, I've not even, had time to counsel a woman and she's come in 3rd month and she's come convulsing in labor in the 9th month and I opened her papers, it's my handwriting. I had seen her in the 3rd month and I was like racked with guilt, right? Did I not counsel her enough? Did I not tell her about dangerous signs? Why didn't she come back for antenatal care? So if it can happen to me, it can happen to any nurse, right? You can't blame the health system, doctors and nurses because it's so overcrowded. It's impossible. 2 hours, you can't be seeing so many patients. And that's the whole system, systemic issue that's happening, right? Pervasive systemic problems, right? I saw this over and over again, right? Completely preventable issues leading to mortality. Women and children ending up dying very late. And I realized that, we were doing heroics in Cama Hospital, really heroic. 70% of women and children who ended up in Cama Hospital were high risk those days. And we realized that, if I really want to impact lives, I have to go into the community. Ensure that these risk factors are picked up early and treated in time before it's too late, right? And I tell you the systemic issues in the country, right? If I were to add a theoretical lens to it or, what is happening in the public health system, see over the last 30 years, there has been this whole emphasis on hospital-based delivery. There was this paper that came out 20, 30 years ago which said that if you have hospital-based delivery, you're going to have 40% reduction in mortality.
Yes.
Right? So then what has happened is all over the world, and in fact India, the government of India has been doing a lot of effort to ensure hospital-based delivery.
Yes.
And that is
encouraging women
to go to hospital
and not have midwife deliveries at home or in the village.
Yes. Now that's a good thing to do, go to the hospital, because you don't die is untrained, there is a lot of untrained stuff going on, so you want to get them to the hospital, and that's led to impact, right? The proportion of deliveries that happen in the hospital increased from 24% to almost 86% in the 2015 if you look at the data. That is great, but what has happened is it's not been matched by equal emphasis on antenatal care and infancy care. What I realized over and over again is that the focus on hospital-based delivery has not been matched by equal emphasis on antenatal infancy care. So what happens is that 86% women deliver in the hospitals, but only 21% of them get full antenatal care. So what happens is that women on the one hand are not aware of the danger signs, the care to be taken during pregnancy and infancy. They demand care late, that's why. And on the other hand, the health workers, right, the ASHA worker, who's a frontline worker in every village in the country, the nurse, the auxiliary midwife, who's the first health worker, in the system. I mean, the trained health worker in the system, and then you have the medical officer specialist. This entire cadre is not trained to be able to pick up risk factors early enough before it's too late, right? So what happens is that either everybody is irrationally sent to tertiary hospitals, or it's delayed, right? So their women, children end up in a complicated state, or extremely delayed. That leads to overcrowding of tertiary hospitals and leads to increasing maternal child mortality and morbidity, right? So I knew that I had to go into the community and ensure that this does not happen over and over again, leading to the high mortality and morbidity. And the thing that struck me was that I had to create scalable solutions. India's magnitude of problem is so huge.
Yes.
At that time when I was thinking of ARMMAN, most NGOs were community-based NGOs, and that's great. Every work done, please, I respect it, and it's important, right? But a lot of Indian NGOs tend to be in, a group of villages, or urban India, urban slums, and they create very in-depth programs in those places. But problem is that if you do not design for scale from day one, it's very difficult to scale across programs that depend on creation of health workers of your own, right? You're creating your own parallel network of health workers. And I realized that because the magnitude is so huge, I had to create solutions that are designed for scale from day one, right? And not create my own parallel network of health workers. And so you work through the government health systems, you support it, build it up, right? And then the mobile phone had already come into India, and within no time it spread through the country.
Yes.
And when I was in Kumta, we are all from Karnataka, and the Gaudis, the tribal women of North Karnataka. Once when I was visiting rural India, Karnataka, my native place, I saw this Gaudti, on the phone, talking to her next employer, realized that it was such a wonderful tool to reach out to women with information when they need it, directly in their homes, as often as they need it, and in a timed and targeted manner, weekly, because things are so dynamic during pregnancy and infancy. So I can handhold women through pregnancy and infancy. And on the other hand, I can use the phone to actually train health workers at every level of the cadre, right? So the same problems, that women have is faced by the ASHAs, the nurses and medical officers, right? Access to information is limited, right? On how to take care of the women who come to them, the children that come to them. So it is such a wonderful to reach out to them with regular information, training, hand-holding. When they go into the field, they have any queries, they have somebody to go and ask questions from, right? So it became very apparent that I should use technology to create cost-effective, scalable solutions. And because it's designed for scale from day one, it could spread through the country in no time, right? Like a non-linear growth. I didn't have to create this whole, huge machinery.
Infrastructure,
because it's so expensive, right? If I have so many health workers, right? 3,000.
But how did you use? Was it smartphones? Was it?
Yeah, it's a very good story.
How do you use phones to sort of?
I tell you what happened. When I was thinking of ARMMAN in 2006, 2007, I had joined Stanford in 2008. And that time iPhone had come to the world, right? I mean, and my friend had iPhone. I had this feature phone, right? And very obvious to me that not only is the phone available to almost everybody, I realized people are going to upgrade by themselves, right? Those days when they talked about technology in health, right? There was no mHealth, there was no mobile health at that time. And even when they talk of using technology, they would create devices, right? And I realized if I create a new device, it's not going to spread across the country. In a country where primary health centers don't even have a BP machine, I can't be creating my own device and expect it to go through the country, right? I had to use what is available in their own homes. Secondly, the iPhone told me that in no time, something like that would be in the hands of everybody.
Right.
Right? I mean, that time everybody had feature phone. I had a feature phone. Yeah. But the future was obvious, you know. I remember the craze during the iPhone, you know, launch in the US. I was in Stanford at the time. And it's happened, right? Now, literally, all ASHAs have access to smartphones. Yes. All nurses have access to smartphones. Yes. The government is giving tablets to all of them, right? And almost 50% of households, have access to smartphone in the country. I mean, we recently did a study in Mumbai where 72% women had access to smartphones. Obviously, the proportion rule in India is far lesser, and there's gatekeeping from the husband and the in-laws. But husbands have access to smartphone, right? So you can use that to create multimedia content, two-way communication, long-term hand-holding. So we started off first with voice calling. Like at that particular point in time, both these services for women directly and to the health workers who was using voice calls, because that time people had only feature phones. So on the side of women, we started off with a program called Mitra, Mobile Mitra, which is a voice calling service. It's a free voice calling service, timed and targeted to the age of pregnancy, age of the child. Would send information directly to the phones in their chosen time slot and language preference. Because if they don't have a phone, then they can ensure the husband's phone is with them. And there are 141 messages through pregnancy and infancy. We would enroll women in government hospitals, like so 100 hospitals, we had our own health worker station who would enroll women in their first visit. But women come to the hospitals too late. So we had formed partnership with almost 40 NGOs on the ground, and through their incentivized health workers, around 7,000 health workers of other NGO partners were incentivized to enroll women when they anyway went to the field, right? So that their work was complemented, and we would enroll women as early as possible. And then, over time, it took me 5 years to get the first penny into ARMMAN. It was so difficult to convince anybody to support an NGO, started by a homegrown Indian NGO, started by an Indian woman, sitting in Stanford, and student, right, that support the creation of scalable solutions by homegrown Indian NGO, because mostly it is the multinational agencies developing these kind of programs, and MS was so new. It took me 5 years to get the first penny, but once we did, within no time, right, we reached 2.7 million women, like a couple of years. And then Government of India noticed us. So they asked us to manage their program called Kilkari. Yes. And Kilkari is in 19 states now. Kilkari is a program similar to Mitra, Mobile Mitra. And again, it sends information to women and through pregnancy and infancy. So basically, a woman is registered while she gets pregnant. Yeah. And then she gets information from you saying, okay, you are now in your 4th month. Yes. You need to get this blood test done. You need to, not only blood test, it's soft messaging also. Like, your baby inside of you is of this size, now it's opening its eyes maybe, or when the mother is, delivered a child, like when the child will understand color, psychosocial stimulation of the child, even the soft messaging, not just the big picture, get this blood test done, get iron supplementation, etc. So the thing is these women are like you and me, right? They want that hand holding, they want to understand little details, like why do I feel like eating mud, or things like that, right? So when you go to government hospital, very difficult to have time to give this smaller and you have so support. Many questions. Yes, who's going to answer those questions? They deserve to have all their questions answered. When you go to them weekly, twice a week, you can answer all of these questions. And MBA was supported by a missed call system and a call center. So basically what happens is that you are enrolled, and start getting these voice calls. You get 3 tries for every voice call, every message, on 3 successive days in the time slot that you've chosen. And if you missed all the 3 tries, then you have a missed call system. Okay. You can give a missed call system, will call you back, and a call center also. We have 30-member call center. Any query you have, you can call back. Because imagine, even if you're working in Mumbai slums, there are pockets of rural poor here. You're talking about girls, 18-year-old, 19-year-old, who've lost the community, environment of their villages. Yes. Come to Mumbai, staying with husbands, isolated, and they've not even met their husbands much before marriage. They don't know who, they're really married to, in illegal settlements with no support, and suddenly they're pregnant, and they don't speak the language often, and then it's very apathetic government health system. So, this emotional support that Mitra could provide, was something that really was transformational. I tell you, and I must tell you this story, right? It's like, as a typical doctor, when I created Mitra, the whole idea was that, I send information, women will listen to it, so they will have knowledge recall, a technical term, and then they will exercise behavioral change. That's how our communication goes, right? And I didn't realize one very important thing was that information is empowerment. you know, these are women who are smart. They're not poor, you know, deprived women who don't have understanding of what actually is right. You know, they have a sense of justice, but they don't have the access. The minute you get this information to them in an elder sister voice, there's a call center, they transform their lives. So I give a story of, you know, this woman in Mumbai, Andheri slums, right? There was this, you know, Azan preacher's wife who, you know, had got pregnant, delivered, and within the first 3 months got pregnant again, right? And she realized something is wrong, right? And she realized too soon. But then, of course, you know, when you get pregnant, you have to continue the pregnancy. Yeah. And then second pregnancy, she got Mitra. And Mitra spoke to her about spacing, that you have to ensure 3 years between your, you know, first and second children, or like second and third. And then suddenly it validated what she already knew was true inside, right? And she stood up, right? She convinced her husband that we have to undergo family planning, that this is second child, we're going to end with this, right? Same thing with, you know, another lady who, you know, was from a conservative Hindu family, right? And Mitra came to, you know, her phone, and then she would take that information and stand up to patriarchal dynamics at home, right? Her mother-in-law had certain views based upon what she knew from before, and she would use that knowledge that she learned to stand up and say, no, I'm going to do it this way, not that the way you're talking about, right? So empowerment, I tell you, is the more, you know, transformative thing, because intergenerational, right? They not only get empowered themselves, they then pass it on to their girl children, right? Because you know, that's what is required, right? And that is the change I've been seeing, and we're seeing this change world, countrywide. And the thing is this, right? When I started off Mitra, I was told like, no, this is just too futuristic. Who's going to give you a phone number? These are women who don't even speak to their, you know, and friends. They only speak to their husband or mother-in-law. They're not allowed that access. But believe you me, right? The most underprivileged women in the most underprivileged places access it more than the women who have, you know.
How many women do you have? How many women have you reached through ARMMAN so far?
Oh yeah, so it's 30 million women now. Yeah, so Kilkari is in 19 states. So together, Kilkari is 28 million and Mitra is 2.7 million, together 30 million. And our goal is to reach 70 million women and their children through the country. In the next 3 to 5 years, they'll be through the country. And this is on the side of the women.
And so, by actually making a phone call, and I'm simplifying it because obviously it's far more complicated than this, by making a phone call regularly to a pregnant woman, giving her...
And mother for the child.
Till the child is 1 year of age. And giving her the information that we take for granted from apps like What to Expect When You're Expecting, where they tell you that this your baby can now taste, can now do this. Now you need to make sure that your baby is getting enough sunlight, something. You were able to save lives.
Absolutely. And you know, I mean, maybe you can cut this later on, but I must tell you another transformation story, right? You know, something like sex during pregnancy, right? No one talks about it.
Yes.
Right? No one talks about it. And this is something that afflicts everybody, right? I remember, you know, there were some donors who would come from the US and we had taken them to Mankur slums. And there were burqa-clad women sitting and talking to these donors, and one of them spoke about this. Mitra came and spoke to me about sex during pregnancy, and that was something that was really bothering me. She said this in front of a large audience. They had got the, you know, courage to speak up things that no one speaks up about. And not them especially, right? They don't have the agency to speak about it, right? So not just the big picture information, you save lives, of course, by like the big picture information like, okay, taking iron supplementation, taking tetanus injection, nutrition during pregnancy, but this softer messaging builds trust and emotional support. They feel that somebody is with them, right? They deserve this. And so the whole idea is that if you inform, women will access care. And now going forward, we're going to have something called as fit for purpose approach. I tell you, this is very important, right? So when we first created M-Health based solutions, it was through an equality lens. I have a product, everybody's going to get it, right? And we hope that they'll access it and listen to it. But while we are, you know, we build our product, we realize one very important thing, that it's not an equality based, issue at all. There's a whole inequity that's happening, right? If you are from oppressed classes, if you are, if you are a migrant woman, tribal woman, Muslim woman, if you are, a young woman, right, young mother, your access is severely limited.
Yes.
Severely limited. There's enough evidence that says that, all of these 5-6 categories, right, their healthcare access is so poor in maternal, during the maternal, and child health phase. So we are going to create something called a fit for purpose approach, and that's what we are now transforming to. What is that? Like depending on technology access. So if you have access to feature phone, we send you voice calls. If you've got access to multimedia, smartphone, we will have multimedia, two-way communication, all of that, long-term hand-holding. But if you've got a risk factor, right? If you are a mother with a risk factor, a child with a risk factor will handhold you much more.
Yeah.
We'll have more targeted content, more two-way communication. And if you're equity encumbered, if you follow all of these inequity parameters, we're going to have even more hand-holding. So we're doing a pilot in Bastar, by the way. Like Bastar is like the last mile of the last mile, right? Literally, it's like the Maoist affected area. So we're doing a pilot with UNICEF called Swabhiman, where we actually hand-hold of women through the self-help women's groups. Because these are parts of the country where even the ASHA workers may not have enough access. They may speak a language the ASHA worker is not speaking, tribal parts of the country. So the self-help women's groups are drawn from the women themselves, right? So through them they're reaching out. So we have this fit for purpose approach, we call it.
So, you know, and it's amazing work, and you talked about far-flung parts of the country, and you talked about tribal areas that don't have access. A lot of my audience is urban, haven't really spent too much time in rural India. We assume from the films that we watched, we know what rural India is like. But in terms of access to hospitals, access to doctor, access to healthcare, for someone from an oppressed caste or someone who is tribal, it is still terrible, isn't it?
Absolutely. You know,
tell us what you've seen.
Yeah, I must tell you this, right? It's like, you know, typically like when you join medicine and you know how it is, right? And I must say this to you, right? And I'm a typical Mumbai product, right? And I so-called came from a lower middle class family. So when I went to medical school, the people who are, from the reserved communities were often richer than me. So you have this whole thing of, oh my God, like they are earning more than me, and I am, I am a open merit candidate. And then really, I mean, when I went to rural India and I saw closely, how being from an oppressed class really impacts access to so many, services, including healthcare. I was really chastened, right? I'm going to tell you this one story. It's just 3 hours away from
where we are sitting right now.
Where we are sitting here, right? There was this, one thing I must tell you: Indian villages are caste-based constructs, right? If you go to any village, it's like you're going to have the Brahmins staying together in one place, and the Kshatriyas, and then you have the OBCs in one place, and the SC/STs, and the Adivasis are like really in the far-flung, parts of the village. And I remember this was really shocking to me. I went to this village, and so the Adivasi part of it was on a hillock. Away from the main village.
Yes.
Right, and there was no, access to running water there. There were toilets built by some NGO, but no access to water. So obviously, running water, so it's not being used. So there was open air defecation. There was no, road that went down from the hillock all the way to the village. So during rainy season, it would get washed out completely, right? It was, and so then it was very difficult for children to go to school, right? And so then I had seen children there who had not gone to school because 4-5 months of the year, if it's washed out, there's no school, right? Yeah. Same thing, when women get pregnant and they need to deliver, right? They have to obviously make makeshift stretchers to carry the woman down, and during rainy season, the access is so difficult, right? So this is the pathetic state of our country in many parts of the country, right?
So already, forgive me, already healthcare is an issue for access among a lot of people, but within healthcare in India, women are second-class citizens, aren't they?
Yeah, absolutely. So there are 2-3 aspects to this, right? The second-class nature of womanhood starts from childbirth, literally. You obviously know of sex selection issues. That's still happening. And by the way, it's more in urban India than rural India. It's crazy. The numbers are worse in urban India or rural India because they have access to technology. So you can use technology to actually,
to be able to determine
whether you want to have a girl child, survive, right? But then what happens is that, progressively, right, access to, neonatal care, access to nutrition, it suffers from the time a girl is born, right? So there's almost 20% more female deaths under the age of 2, right? As compared to male children, right? Even though girls have a biological preference, so actually you should have more girl children surviving, but because their access to healthcare is limited,
and
there's
nutrition,
nutrition, exactly. And then seeing there's an intergenerational chain of nutrition, malnutrition, right? So you have an undernourished mother who gives birth to a low birth weight child.
Baby.
If the child is a girl child, and she remains undernourished more often than the male child, and then she becomes, a stunted, girl child. And the number of children, girl children who are stunted is far more than boys. And then she becomes a, a malnourished adolescent girl who then becomes
married again.
Yeah, and married again early, and intergenerational. And one thing I want to tell you,
half the adolescent girls in our country are anemic.
Anemic, for more than 45%, right, in Mumbai, right? So you're talking about, urban India. But the thing I really want to point out, and this is something that really, really bothers me, the gender preference I see so much in my own field, right? If men had delivered babies, the impact of the delivery on their body would be paramount. There would be so much research backing
books written about it. Films would be made.
Absolutely, the sacrifices made and all of those things. And the thing that really bothers me as a Urogyne, I am the chair of the Foundation of International Urogyne Assistants, and this is something that we really want to talk about world over. And it's world over. And India obviously is far more because of the patriarchal norms, etc. The concept of maternal health ends with delivery.
Yes.
Right? It is something shocking. Right? A mother carries such a huge baby inside of her for 9 months. It's obviously causing changes in her pelvic floor. She's delivering, that big baby through her pelvic floor. There's so much damage and known damage. There's enough research backing it that you have muscle damage, soft tissue damage that's happening. But the minute a baby is born, it's over for the mother, right? They'll just look at whether she is bleeding, whether the uterus is involuted, all childbirth, related things. To do with immediate, emergency issues. Yeah. After that, she's completely forgotten, right? 1 in 3 women.
After that, she's completely engaged in childcare.
Absolutely, she
doesn't have the time to chill.
No, she's engaged. The family is engaged. Who's bothered about the mother, right?
Yeah.
And I see this in urban India also. Nobody tells you during pregnancy of what is important, potentially, going to happen to you after childbirth, your pelvic floor. 1 in 3 women suffer from pelvic floor disorders. Right, so you talk of urinary incontinence, fecal incontinence, prolapse, right? It's so common, but the only pelvic floor problem that has got any importance in public health is fistula, right? But that's extreme. For every woman who has got fistula, 100 more suffer from urinary incontinence. If you're a Muslim woman, quietly, because it's a silent emergency. It deals with a part of the body supposed to keep modest about. No one talks about it. Like I have patients, urban women, coming to me and saying, "Oh, I thought it's very common. My aunt had it, my mother had it, everybody had it. So I thought it's okay, it's normal." I have very highly educated women coming and telling me this. I have seen highly educated women coming to me with the vagina, anal canal as one cavity because all ruptured. It can happen to anybody, not even rural women. It can happen to urban women also, but no one is prepared for it. And the point is that what bothers me is there's no public health approach to women's body, right?
Yes.
It's very curative. There's no preventive approach to it. Yes. And the point is that people who deliver, right? Some of the urban specialists may be aware of how to prevent pelvic floor damage, but rural India, the nurses who deliver, or the district hospital specialists, etc. They don't, and medical officers, they have no training on how to prevent perineal trauma, how to screen for it, how to pick it up, and where to send. Right, and really, something that's shocking to me, and one big 5-year plan, is to actually advocate for the concept of maternal health to be expanded, to include all that happens to women's pelvis after delivery, and Urogynaecology deals with that, right?
You're doing a lot of this at Cama Hospital right now.
Yes. And before I go on, I must tell you the kind of a story around it, right? Yeah. Stories tells you, the hidden trauma, right? This is a story from Cama Hospital, right? There was this woman who delivered 5-6 years ago and had prolapse. Like 4 months after delivery, her organs started dropping because we have damaged the muscles, so it cannot hold up the pelvic organs. She neglected it. She stayed in the outskirts of Mumbai, did not have access to healthcare, and obviously her husband was a labourer, so really did not have access. And so she neglected it, and then COVID struck. So then COVID, she didn't have access to healthcare at all. For over 4 years. The prolapse worsened to an extent where everything had dropped out. Only 36-year-old. It got ulcerated. So she couldn't sit, stand in extreme pain. And then because it was ulcerated and it was hanging out, edematous, it was become enlarged, congested, she couldn't pee. because urethra was, compressed. So she was retaining urine. So over 2-3 years, she was retaining urine. And that leads to back pressure changes to the kidneys, right? So her kidneys were, of course, dilated, her ureter was dilated, and she comes in that state in the, last year to Cama Hospital, right? And I'll talk about what I do in Cama Hospital. And she comes there, and she was in another unit, and I was suddenly called and said, like, this patient being taken to the operation theatre, come and help us. And I go there, and horribly ulcerated mass coming out, and I operated on her. And then after that, because I've not seen her earlier, she couldn't pee because the bladder muscle was damaged because of his long-standing retention of urine. And, it is just, so difficult to manage her. She had to be catheterized from delivery for literally 3 months. We had to give rest to the bladder. And I'm really grateful that she finally recovered. But if she had not, which was a possibility, right? Because it's long-standing, she could have had to catheterize herself to pass urine. It's called self-catheterization, 3 to 5 times a day to drain urine to save her kidneys. So imagine what can happen to women because of childbirth, the kind of
just childbirth, which everyone will tell you is perfectly normal. Women do it all the time for thousands and thousands of years. Why are you being such a fuss about it?
Because we're second-class citizens, right? I told you, if men had delivered, this would have been such a huge, there would have been so much research around how to take care of. And the point is that even the way medical science is structured, right? Everything to do with human, female's physiology is learned from male physiology. So all the parameters known in male physiology apply to female physiology. And even if you look at how bladder works, all that we know is extrapolated from male physiology, right? Very little research for women, very little emphasis on conditions that affect women, right? So this is something that
and this shroud of silence, right? Over
absolutely.
Everything. Nobody wants to talk about it. Everybody finds it icky, like, ooh, can't you just like...
No, and it's so shocking because this can be faced by anybody. When you deliver a child, it's a very gross situation, isn't it? It's like when you go through the delivery, you realize that you actually come in close to your body and you see what the body goes through, but no one talks about it.
No one talks about it.
Yeah, people start talking about menstruation, but I really think that women should start talking about their pelvic floor and what happens to it when they go through something that almost every woman will go through.
And you're expected to be boom, normal.
Yeah,
immediately after.
Absolutely. And because the child is more important, right? And like postpartum depression, postpartum blues, that nobody cares about that. You're supposed to feel immense love for the child as soon as the baby is born and not realize that you're going through so many changes, right? Hormonal changes, physical changes. No one gives time to the mother.
And this is all, you have such a beautiful baby, why are you not happy?
Yeah, absolutely. And that's the whole point, right? I tell all my friends that no matter what happens and no matter what you feel, it's okay.
Yeah.
Right? And so, it's the thing that we need to give all women, right? That it's okay. Like when you deliver a child, no matter what you're going through, it's all valid, right?
Yeah.
So that is not, that support is not given to women, even urban women.
Cama Hospital has a fascinating history.
Absolutely.
And we'll get to what you're doing in Cama Hospital. But take us through that story.
Yeah, when I joined Cama Hospital, I was, really amazed to hear its history. I'm a history buff, so I went into this whole, literature on it, and I was stunned to find that Cama was the first women and child hospital in the country, right? It was built in 1886. And, till then, till 1886, there were no female gynecologists, right? So if women had to deliver, they would be delivered by dais, and because you can't have a male doctor next to the woman, you would have the male doctors behind the parda,
direct instructions,
to the dai, and that would lead to mortality, and it's something very shocking. And then Cama, who was a Parsi philanthropist at that time, and Kittredge, Bombay Natural History Society, he was the founder of that, right? They got together, and Cama, donated money to build Cama Hospital, and Kittredge created a female doctors fund, a women's doctor fund, All India Women's Doctors Fund, to get doctors from the UK, because trained physicians were only in the UK, right, at that particular point in time. And Cama was built, and with the princely sum of, I think, 10,000 rupees, which would be like huge pots of money now. And I went to the story of all the female doctors, right, of that time, and the first one is Edith Phipson, who became the first superintendent of Cama. And apparently she was a part of Edinburgh 7, so those days, even in UK, you couldn't do gynecology. You could become an MBBS, but you couldn't do a specialization as a female doctor. And so they fought a court case, right? It's called Edinburgh 7, I think, right? And to allow women to study further and beyond MBBS. And that time only Scandinavian countries you could do gynecology as a woman, right? And so she was the first batch that actually could do post-graduation. And then she scales that, that
mountain.
Yeah. And then she decides to go, 7 seas across to India, comes to India and becomes the first superintendent of Cama. She had this small, clinic also in Tardeo, I think. And Anandi Bai, the first female doctor, I think, they raised funds to send her abroad and, so Cama has that history. I mean, this first 7 doctors of Cama, I mean, the personal stories are so amazing, for them to actually build that hospital in the manner that it has, right? And when I joined Cama, it was like amazing to know that, the kind of women on the shoulders of whom we are standing, right? I'm here in front of you because of what they did, right? And what Anandi Bai did, right? And to know that they have walked on those, hallowed corridors really gives me goosebumps. You know what I mean? Because, when you go to government hospital, you lose sight of, what history, supports it's behind it all, right? And you don't realize that there is immense bravery. Absolutely, right? It's like the whole sense of purpose, right? And why did they become a doctor? Like for me, it is science, service and research, and ARMMAN has given me that purpose and Cama has given me that purpose. And then to know that there are women behind me whose purpose has led to me having the agency to have purpose, right? I mean, so it's just astounding. So I am really hoping that when I build a department, I have their photographs, always, towering over, us when we, are doing our work in Cama, right? So,
Tell us about the department you've built, because urogynecology is a really rarely spoken about field in India, even in private practice.
Yeah, absolutely.
But you are creating now a state-of-the-art department that would be completely free to access for women.
Absolutely, absolutely. No, so when I got back from the United States, one was obviously to scale ARMMAN through the country, but second thing was obviously get Urogyne to the country, but also to get it the government health system, because I wanted the poorest of the poor to get the highest end care for free in an environment of dignity and privacy. Our government hospitals have so much, potential, right? I mean, the kind of patients we get, the kind of, amenities that can be made available to women, the potential is immense. And I knew that I want to build a fellowship program, but I want to do it in a government hospital. And I must tell you, the government really supported, me through the whole thing, right? It's taken me many years. But Maharashtra government, I had signed a MOU with the government of Maharashtra under the Maharashtra Navnirman, Yojana, to create this whole Department of Urogynecology at Cama Hospital. I work for free from 8 to 1 a.m. every day.
Okay.
Yeah, and then I do private practice in the afternoon. But Tata Trust is supporting the entire initiative. It's given me a 2.5 crore funding literally for all kinds of equipment. The kind of equipment that's come to Cama is the highest end, public or private in the country. So my private patients will have to come to Cama for certain things that is not available at all. Wow. And not only that, they give me a 2-story structure.
Okay.
And the whole idea is that the structure is going to be designed in a manner that will give the highest end care in an environment of absolute dignity and privacy that these conditions deserve. That and so that no woman is rushed through the system. There's no overcrowded clinic. That they'll be seen by appointments, right? And then they will get the kind of care they deserve, right? So not only that. I'm going to create a fellowship program. Hopefully, it's a department. Obviously, hopefully, is going to be through, and a separate Department of Urogynecology, and a fellowship program. So the whole hope is that I can create a fellowship program where there will be peer group that the fellows will encounter that will actually get them close to why they want to be a doctor. Right?
So basically, you're also training other doctors, right?
Absolutely. So there's no Urogyne. I'm going to start the fellowship program. I was waiting for the department to get created. Obviously, I train here and there, but now it's going to be a concerted university-based program, hopefully soon, after the department is created. That's the vision behind it. They'll have a hopefully 2-year fellowship in urogynecology, doctors from all over the country, post-MD Gynac. So the whole hope also is to create a fellowship program so that we can train the next generation of urogynecologists, because if 1 in 3 women suffer from this, you need to have trained doctors to be able to give care all through the country. But I'm also hoping that when they come to Cama Hospital and train with us, they'll go out of the program close to, their purpose of why they wanted to become doctors, right? So no matter where they join later on, private practice, etc., the motivations, the purpose would be as true, to the
Yeah.
true self as possible.
And I'm sure
And
if someone works closely with you, that inspiration will rub off.
I know,
them.
yeah, but it sounds modest, but I hope that, it's like
Yeah.
they can see what's possible, that is really, it'll inspire them to kind of, really go ahead and do this.
So it is possible for our government hospitals to be able to provide world-class health
Absolutely. Not just
for free
with
with
poorest
dignity.
women, with dignity.
With
That is
dignity,
what Cama is going to do. It's already, a beautiful hospital. You must see the hospital where, obstetrics gets done in better environment, very good environment. But another thing I'm really excited about is also research, right?
Yeah.
India needs to, contribute to research internationally. And I am a researcher in 2D, 3D ultrasound on the pelvic floor. So it's been my research focus. I teach it internationally. That has come to Cama. And I'm hoping that because I'm a researcher, my fellows will do world-class research.
Yeah.
I'm dreaming, of this time when my fellows will come to me to international conferences, present work from Cama Hospital, which will be cutting edge. Like we used to go from Cleveland Clinic under my mentor, Dr. Davila, and present papers in international conferences. I want to have that happening, where,
Out of Cama Hospital.
Yeah, research highest, and it's possible. I mean, I tell you, my private patients will have to come there. And the thing is that I have got funding also to renovate the space. They've given a 2-story structure. They're behind the whole dream. I mean, the superintendent of Cama, Tushar Palve, the government health system secretary, the director of medical education, everybody is behind it, right? And full support. And they're given a 2-story structure. It's going to get renovated. So the outpatient clinic downstairs and individual room for diagnostics upstairs, so that it will be extremely high-end care, right? One thing that really I believe in, and I want that happen in the country, that no one gets denied really proper care, appropriate care, and in the right kind of environment, just because they're not able to afford it.
I read a lot about it, that even during COVID, for example, women really suffered more, suffered longer, specifically women in need of care and health care, which was either gynecological, urogynecological, in that space, which is already shrouded in silence. You're too embarrassed to talk about it. During COVID, it became that much harder. And do you think, and I don't know if there's data out there now, the last I checked there wasn't, do you think that Indian women will probably take longer to recover from COVID because of what they went through at that time?
There's no data on this,
yes,
but then there is enough anecdotal data on the fact that yes, women have come to the hospitals too late, right? There's been delayed care. I mean, we've personally seen many women losing their babies because they access care too late, going through immensely horrible sequelae because the access to care was delayed, right? Because women are the caregivers, right? They are not the care receivers, right? They are the ones who are going to look after the families, and their problems do not are not primary. So this is something that 100% has happened during COVID, and then women's access to family planning, women's access to abortion, right? All of us that suffered, right? Women's access to antenatal care suffered really tremendously suddenly. And the thing is this, right? They suffered more because pregnancy and infancy are dynamic periods. They can't wait for a lockdown, right? You can't say, oh my God, like let the lockdown get over, then I'll access care. I mean, things change week to week. If you need care immediately, right? And then those days when suddenly the lockdown was announced and suddenly hospitals became COVID centers, they didn't know where to go, and what care they needed, where to get the ultrasound done. I have seen instances where women have walked kilometers to reach their hospital only to be told that the hospital is shut down, become a COVID center, then again walking many kilometers more to another hospital, just running from hospital to hospital for access care. So because of the conditions that we deal with are so dynamic, women obviously are going to suffer far more than men do, because women deliver.
You did talk about the fact that with ARMMAN you're putting out information, but you're also working to create an entire workforce of healthcare professionals.
Yes. So the way ARMMAN works, our theory of change is that on the one hand, if you inform women about the care to be taken during pregnancy and infancy, they'll demand care. But on the other hand, we have to ensure that primary care and referral system works. That means the health workers at every level of the health system are trained to be able to pick up risk factors in time. And for that, what we're doing is that there's a program called Mobile Academy of Government of India. That's the mobile health based, refresher training program for ASHA workers. Now, there's an ASHA worker in every village in the country, right? And the only refresher training they get is this one called Mobile Academy.
Okay.
Yeah, and it again is in 18 states. 252,000 ASHAs been trained. And now we're going to go on to multimedia approaches, because most ASHAs now access smartphones. So we're going on to version 2. So more two-way communication, more multimedia, more long-term hand-holding. And we saw that in COVID, right? We were sending off information to ASHAs the Government of India needed to send through our whole databases that we had, right? And imagine we have these ASHAs all through the country, in close link with us. We're doing refresher training over any new pandemic, we can train them through it. If they have any questions in the field, we can answer. So it's going on to this long-term hand-holding, call center, WhatsApp support, etc., right? But we also work with nurses, medical officer specialists. Now, one thing I must tell you is this, right? And see, in urban India, if you become pregnant and have a risk factor, an obstetrician will manage you end to end.
Yes.
She'll pick up the risk factor, manage in time, and you obviously recover. But in rural India, what happens is this: you have a 3-tier system, right? You have the nurse, the medical officer, and the specialist. Now, the guidelines for management of high-risk conditions have not been created for them. They've been created for the obstetrician sitting in urban India. So when a woman with a risk factor goes to a nurse, she has no idea about what is her part of the role. What is she supposed to do? What counseling she's supposed to give? What medication to give? And when to refer to the medical officer. The medical officer, who's a homeopathy doctor, Ayurveda doctor, even an MBBS doctor, really not trained to understand what is his or her part of the role. And by the time the woman comes to the district level hospital specialist, it's too late. And even the specialist in the district hospital may not be as trained as an urban, doctor. So we have a huge program called Integrated High Risk Pregnancy Management. What we're doing is that I highlighted this problem to the Government of India. I was a part of the Antenatal Care Guidelines Committee, and I had said that we were revising the antenatal care guidelines, and I said that we need to really create protocols that really lay out to the last detail, everything that each cadre is supposed to do for every risk factor. For 35 high-risk conditions, me and my team had put together these protocols. And on Telangana, we're doing this whole program where it's become policy. Now we're training 9,500 nurses, 1,500 medical officers, 350 specialists, in all of these protocols. Now, not only that, all of it is going to become multimedia. Like for the ASHAs, we're going to have multimedia content on their tablets. So we have guided training, multimedia, simulations, interactive quizzes, long-term hand-holding. So we train you, we guide you, and then you go to the field, have any queries, you can ask us on call center, WhatsApp, and then we'll track you. So every pregnant woman, they are part of a database, the Government of Telangana. Like every pregnant woman gets into a database. Every state has it. The minute they get high risk, we'll be able to track them because the protocols will be embedded into the database. We can track them end to end so that we know what is happening, right? And so that we can lead to dashboards at every level. So that we know if a part of Telangana is doing very poorly in pregnancy-induced hypertension, we can go back and do a refresher training. So this 5-year thing we're doing, we're hoping that it spreads to the country, So we go through the entire, primary care and referral system. Our whole hope is that all of it is, every level will work so that women don't end up in a dying state, children don't end up in a dying state. And I must tell you this, and something that's exciting for ARMMAN is that though we do grassroots level work, because we deal with such huge amount of data, we work with Harvard and Google on applying AI to this data. And in fact, we've created, there's a great team in, under Milind Tame, who was like a part-time Google and part-time Harvard, created this first real large-scale model of being able to, predict, who's going to drop out of the program. So Mitra now, we can predict at the time of enrollment itself, because we've done machine learning of data, who's likely to drop out. So we have a decentralized way of getting the woman back in the system, because we know if she listens, then she's going to have better health care, So we are also on the cutting edge with ARMMAN, right? And the whole hope is that, in Telangana, it's like our, future, right? Kilkari and Mobile Academy are going to go to Telangana next. So all the databases are going to talk to each other. So imagine if a part of Telangana is doing very poorly in pregnancy-induced hypertension. Kilkari can inform the women more, Mobile Academy can train the ASHAs more, and Integrated High Risk Pregnancy Management Program can train the nurses, medical office specialists more. So we have this, 360 degrees approach. Yeah.
Thank you so much for giving me your time. I think that, like me, many people in the audience will now be in love with you. Thank you so much for the work that you're doing, and I do hope that the dreams that you have for ARMMAN all come true.
Thank you so much. Thank you for having me here, Faye, and your support has meant a lot over the years. Yeah, and you know, I just want to say that, you know, I'm just lucky. I mean, this sounds like a lot of immodesty, but the thing is that I feel gratitude that I have ARMMAN in my life, that I got the chance to build something like ARMMAN and to do Cama Hospital. Like this, these two things that are so close to my heart. It's just, I'm lucky that I get to do this, you know. So, and this purpose, you know, that I found keeps me going, because it keeps me going through the worst of times, you know. So I'm grateful for this opportunity and life and universe. Thank you.
Thank you.